In this video, we present the protocol for a randomized preclinical study conducted in a large animal model comparing endoluminal radiofrequency ablation with glue occlusion of the main pancreatic duct. These interventions are performed 4 weeks prior to surgery with the aim of inducing pancreatic atrophy and potentially reducing the risk of postoperative pancreatic fistula following pancreatic surgery. The protocol consists of 3 sequential procedures: occlusion of the main pancreatic duct, minimally invasive pancreatic transection performed 4 weeks later, and necropsy conducted 15 days after transection. The first step involves preparing the duct for occlusion using a transpapillary approach. 2 experimental groups are treated either with radiofrequency ablation or glue injection, performed via minimally invasive or combined surgery. The first option consists of a hybrid laparoscopic and open approach. Once inside the abdominal cavity, the omentum was mobilized to expose the stomach. The first and second portions of the duodenum, the pancreatic head, and its connection to the duodenum via the pancreatic papilla were identified. In pigs of the selected size, the papilla is usually smaller than 1 mm, making visualization and catheterization challenging without magnification or the required ergonomics that a robotic approach would enable. Therefore, the laparoscopic approach was complemented with a small assisting incision to facilitate cannulation of the papilla. A duodenotomy was then performed to directly expose the pancreatic papilla, facilitating access for the subsequent procedure. In animals randomized to the glue group, cannulation of the main pancreatic duct was achieved using a flexible laparoscopic catheter. Glubran was then carefully injected through the duct, with the catheter gradually withdrawn during the injection to ensure uniform distribution of the glue along the ductal pathway, continuing until the catheter reached the level of the pancreatic papilla. Finally, the duodenotomy was closed using a continuous, absorbable suture. Subsequently, the abdominal wall, the skin of the assist incision, and the trocars are closed. One of the advantages offered by the robotic approach, compared to hybrid approach, is the easier cannulation of the pancreatic papilla, even when it is small. As demonstrated in the video, the enhanced camera magnification and superior instrument articulation allow for precise identification of the papilla and smooth access with minimal tissue manipulation. This reduces the need for multiple cannulation attempts, thereby minimizing duodenal mucosal trauma and preserving clear anatomical landmarks. In animals randomized to the radiofrequency group, cannulation of the papilla was performed using a 3 French radiofrequency catheter, which easily advanced approximately 10 to 12 centimeters beyond the pancreatic junction. Radiofrequency ablation was retrospectively applied until reaching the pancreatic papilla. The duodenotomy was then closed with a continuous suture using absorbable material. Four weeks after the first procedure, duct occlusion should already have triggered asana atrophy, so pancreatic transection is carried out. This procedure can easily be performed through minimally invasive surgery, either using laparoscopic or robotic approaches. Following the stomach, the second portion of the duodenum is located, along with its junction with the pancreatic head. The head and body of the pancreas are then mobilized until reaching the portal vein. The anterior surface of the portal vein is freed from the pancreas, and a vessel loop is sometimes placed in order to help with traction. The pancreas is transected using scissors, followed by a second, more proximal transverse section to obtain a 5 to 8 mm thick sample for histopathological analysis. Hemostasis using electrocoagulation is performed while avoiding coagulation near the pancreatic duct in order to prevent thermal sealing of the duct. Finally, a Blake suction drain is positioned at the site of the pancreatic transection. The animals are finally euthanized 15 days post-transection and necropsy was practiced. A total duodeno-pancreatectomy is performed for histopathological examination of the specimen.